Hello, welcome to the BoardWorks series. My name's Dave Schneider. I'm the CEO of the Northern Michigan Regional Entity, which is the PIHP for Region 2, which is the northern half of the Lower Peninsula. This session of the BoardWorks is about best practices or evidence-based practices. Now I want to give a little disclaimer before I get going. I'm an administrator. I have no clinical background. This is a clinical topic. So you're not going to get a real in-depth clinical analysis of evidence-based practices. What you're going to get today is an overview of how we got to where we are, what are evidence-based practices, how did we get here, where exactly is here, and what are some issues you need to be concerned about as board members, such as sustainability. And most importantly, those things that you as board members should be thinking about when presented with new programs or when asked these questions. So let's start with a definition of evidence-based practices. And if you get in a room of 10 people and ask 10 different people a definition for an evidence-based practice, you will probably get about 20 different definitions. So let's just look at what they are. An evidence-based practice is an intervention with a body of evidence. What's that mean? Rigorous research studies, specified target population, and specified client outcomes. So in other words, there's a scientific methodology backing up what this practice is, how it should be done, and what it accomplishes. There are specific implementation criteria for the practice. And through this research, there is a track record showing that the practice can be implemented in different settings. Now this is tough to do. There is also a role here for emerging and promising practices, and we'll talk more about that as we go along. So evidence-based practices are practices that integrate best research evidence with clinical expertise and patient values. That's a definition from the Institute of Medicine in 2001. And the key parts of that I want you to remember as we go forward is that it integrates the best research effort, but it integrates it with clinical expertise. So there's always a room for clinical knowledge and expertise and patient values, because this is still about the people we serve. Another definition, and this time we'll talk about evidence-based behavioral practices, entails making decisions about how to promote health or provide care by integrating the best available evidence with practitioner expertise and other resources, and with the characteristics, state, needs, values, and preferences of those who will be affected. Again, what we're hearing here is not just scientific research, but expertise and the needs and concerns of the people being affected, similar to the definition we just covered. Now, this is from Wikipedia. I don't always recommend that people get definitions from Wikipedia. It's a free encyclopedia. People do what they want with it. But in truth, it also is a good place to look to get some idea of what people consider to be a proper definition. So how useful it is depends on what you're looking up. But in this case, I think it's a pretty sound definition. Overall, this shift toward the use of and development of evidence-based practices in behavioral health services is moving in a positive direction. However, many of these evidence-based practices that we are talking about are tested in urban areas and are not easily adapted to rural areas without losing key components of the tested practice. Think about that for a minute, the difference between implementing something like ACT in an urban area such as Grand Rapids, Lansing, Detroit, versus a rural area such as Iosco County, Emmett County, in the UP, up in Luce County, where you don't have the density of population. Due to the difficulty of developing and evaluating evidence-based practices, the term promising practice has been used to refer to behavioral health practices that don't yet have that evidence base necessary to be considered an evidence-based practice, but which do appear to be effective based on some less stringent definition of research, evidence, or preliminary or simple data evaluation. So what's that mean? In real terms, it's a good practice. There's some mounting evidence to show that it has value, but it doesn't meet the standards of an evidence-based practice. The term best practice is used to refer to a practice which is generally thought to be effective based upon anecdotal evidence, but for which objective data is lacking. So again, we try to move toward evidence-based practices, but we still have to rely on promising and best practices. Definitions of emerging and promising practices: essentially practices for which specific evidence is building, it's not there yet. Ongoing research is necessary to validate their effectiveness, and that's being collected. And they address a widely held client need or gap in the service system. See, that's an important thing to remember. There aren't evidence-based practices that meet every need yet. And so sometimes we have to rely on promising or best practice. So what's the definition of a value-based practice? Practices for which the research base is currently limited or inconclusive with regard to effectiveness, but they are approaches that consumers and families request and find helpful. In other words, they have value to people. We don't want to throw them out just because the evidence isn't in place yet. So they still exist, we still use them, but where possible, we should be moving to the evidence base. So all that having been said, there are concerns about evidence-based practices. Common concerns, and why they really shouldn't be concerns, include people think that evidence-based practice is not person-centered. Well, it absolutely is, if it's done right. There is nothing not person-centered about suggesting to an individual that the best way to get where they want to get is a practice that's been tested. You're not disregarding someone's dreams and desires. You're not disregarding their desired results of treatment. You are sharing with them a tested and proven means of getting to where they want to be. The example I love is from physical health. I don't know if any of you have had any experience with cancer, but I have with a family member. And we got the diagnosis. The next day we met with the doctor, and the doctor said, okay, someone in this age group with this particular cancer, with this particular stage of development, this course of treatment, 95% are cancer-free in 5 years. This particular course of treatment, 94% are cancer-free in 5 years. This treatment, 70%. And I don't remember the exact numbers of treatments, but the key was, based on evidence, based on research, they were able to provide us with information on what the expected results are from various treatments. Why don't we owe the same to the people we serve? Another concern is that focus should be on outcomes without defining how to achieve the outcomes. Well, I don't know where people come up with that. The focus should absolutely be on outcomes. Of course it should be. But if you know that this is most likely way to get you to the outcomes, isn't that what you should do? Innovation is stifled. Not in the least. Innovation is not stifled. But even so, when people are coming to us for service, are they looking for innovation, or are they looking for proven treatment that gets results? You've got to think about that. Innovation has its place, but I'm not sure it actually belongs in everyday treatment. Evidence-based practice is not recovery-oriented and may in fact conflict with a recovery orientation. Again, I don't see where that comes from. The whole purpose of recovery is to regain the life that you want, to live the most typical life you can. Evidence-based practices are proven to help you achieve those goals, so how is that not recovery-oriented? I think you have to keep in mind that a lot of these concerns are thrown up by people who don't want change. You know, I've done a lot of this over the years, and one of my favorite lines is, change is good. You go first. People resist change. Moving to evidence-based practices is a change. And so people throw up reasons, and they grasp at values we hold and say that, well, this doesn't meet these values. What are our values? Recovery-focused, person-centered, outcomes. And so this starts to poke holes at that. Well, it's not valid. It doesn't conflict with any of that. So don't let people fool you. What evidence-based mental health treatment is? We talked about the concerns. Let's talk about what it really is. It links research findings to patient care. That is so appropriate, and the people we serve deserve that. It links consensus treatment guidelines to patient care. Again, people deserve to have services that are proven to work and generally accepted as getting the outcomes that they need. It emphasizes measurable outcomes. We as a system in a healthcare world have to be able to demonstrate the outcomes achieved. If you think about it, the public mental health system in Michigan spends over $2.5 billion taxpayer dollars every year. Doesn't the public, doesn't the taxpayer, don't the people we serve deserve to have some objective evidence of what we achieve with that money? That's measurable outcomes. It encourages the use of science to refine and advance clinical treatment. We always have to be advancing. Look at how far we've come with medication and what the medicines available today do as opposed to the medicines available 30 years ago. That's science. Shouldn't we continue that in all aspects of our services? And it sets the stage for a process of continually and systematically evaluating effectiveness. We need to do that. As a system, we've been talking for years about a common assessment and outcome measure. I've been parts of work groups where have gotten way down the road on getting it and it never gets implemented. Why? We need to move forward on that as a system, and this helps set the stage for that. What evidence-based mental health treatment is not, it is not the blind application of treatment recommended by researchers. It is, remember the earlier definition, it takes scientific research, mixes it with clinical expertise and the particular needs of the consumer involved. That's not blind application. It is not cookbook care. Again, remember the earlier definition. It's taking tools and applying it to the situation at hand. Ivory tower care, where does that come from? Here's part of it. They can be expensive. Training for it is expensive. And so people, again, detractors will start coming up with everything. Oh, that's ivory tower care. I've been in administration long enough to understand this. We are always accused of living in an ivory tower. Not true. Simply not true. This is the use of proven methods to treat people. Just another name for what clinicians have been doing all along? Not hardly. In some cases, maybe just a little bit, but not hardly. This is changing how people do things to use somewhat prescribed methods as applicable to the individual at hand. You know, I can remember way back when I first started in this system, a therapist telling me, you don't need to look in my records. What goes on when I close this door is good stuff. Well, that was more common than people like to admit. The whole concept 30 years ago that someone would come through and review records was appalling. Now that's a way of life for us. We've moved a long way. This is not the way we've always been doing things. And it's not just what we've done, but a different name. All right, so that kind of gets you what they are, what they're not. Let's talk now about why we should use evidence-based practices. Well, evidence-based practices provide a solid foundation from which to help a consumer. Remember my cancer story. It was so comforting to have the doctor tell us, in this situation, this treatment gets this result. This treatment gets this result. And it's based on fact. It's not based on anything, well, I think what might be best for you. No, it was based on giving a solid foundation of information to make decisions. More likely to get the results you want. And that's absolutely true. We owe it to people to be able to help them get where they need to be. And if there are methods out there that show us that in X% it's proven to work, we should make that available. And again, provides evidence of effectiveness. Back to the whole outcome measurement thing. We need to be able to prove that we accomplished something with $2.5 billion. Improve the quality of life, improve functional ability of people we serve, improve their quality of life and their capacities. Tying treatment to outcome assessment allows for more informed clinical judgment and clinical decision making. Let's think about that for a minute, because for years people have said, oh, you know, this is more art than science. No, it's not. It's science. I've talked to enough clinicians who will say, no. People try to make it all mystical, but it really isn't. It's pretty black and white. And having outcome assessments and information helps a clinician make better decisions. Plain and simple. It's not just clinicians, anyone. The more information you have, the better decisions you can make. And it's a much more rewarding experience for the consumer and the clinician. People want to see results. Consumers who go through this want to see improvement. And clinicians, come on, we've all heard it. They get burned out. There was recently a really excellent presentation about the secondary stress from trauma that clinicians experience. And it's very legitimate in that when you spend all day hearing some of the horrible traumatic things that our consumers have gone through, it takes a toll on you as a clinician. As a clinician, though, if you can see the progress made through evidence-based practices, your job becomes more rewarding. As board members, that should be important to you. So now let's look at what makes an effective evidence-based practice. Let's put it all together. So you've got a consumer's goals and their strengths. And you've got this community of resources available. And you've got their clinical circumstances. So you're starting to see all these pieces that play into this. And then you've got this body of evidence-based practices to choose from. And where all of these meet there in the middle, that intersection of the consumer's goals and strengths, the community of resources available, the individual's particular clinical circumstance, and the right evidence-based practice is what gets you to an effective evidence-based practice. So hopefully that makes it clear. This isn't cookbook. It's not a one-size-fits-all approach. It takes all of these pieces and puts them together to find the effective evidence-based practice for the individual. Evidence-based practices, the new challenge now is to broaden our perspective. We've been doing this for a number of years, and in a little bit I'll talk about how we got to where we are. But now we're not just talking about evidence-based behavioral health practices, we're moving into integrated care. There are additional new challenges for direct care staff, for clinical managers, for executive directors, and for you as board members. No longer can we ignore that someone is a diabetic. No longer can we ignore that a consumer has asthma. No longer can we ignore smoking. No longer can we ignore obesity. And I'm a big boy, I understand this one. But you've got to be aware of the fact that there's an interplay of all of this, and the behavioral health world has to start paying attention. Now, that's not asking people to treat outside their scope of practice. We do not want that at all. So I'm not asking a social worker or a psychologist to treat diabetes, but I'm asking that a social worker or a psychologist is aware that an individual has diabetes and is in tune to it a bit. And you as board members need to understand that. So that's where we're at, but how did we get here? Let's cover a little background. The State Practices Improvement Committee, it's now called something else, but years ago they started out this Evidence-Based Practice Steering Committee. Years ago, the first meeting was July 21st of 2004, so it's been 11 years. This was in response to the Governor's Cabinet Priority Initiative. So there was this Governor's Cabinet priority for moving toward evidence-based practices. They initially had a short 2 or 3 month timeline to document some movement in this direction. Well, this evolved into a number of ongoing groups. We're now over 10 years later. Has this lost its steam? That's a tough question to answer. It has evolved. I don't think it's lost its steam, but it has evolved. The last draft we saw of something different was the trauma-informed care policy. That came out over a year ago. We all gave feedback. It is now part of the contract negotiation going into next year. It's come back with some feedback. So that was the latest policy draft last year. There's things moving along. Has it lost steam? No, I don't think so, but it looks different than it did when we started. The initial approach used appeared to be the creation of an evidence-based practice institute. That's what everyone was thinking would be the best approach. But through a lot of dialogue, a new approach of shared leadership started to emerge. What shared leadership? Shared between MDCH, now MDHHS, the CMHSPs, the PIHPs, and universities. Now why? What's the rationale for this? Well, a lot of people will have some smart remarks about that, about everything's getting pushed down, but think this through for a minute. There was cost savings because it got spread around. Commitment. If you want people to commit to something, people support what they help create. So rather than being an ivory tower thing or something that some institute of the elite developed and pushed down, this was a broad group with collaboration, many people involved, so you get more support. There was also an acknowledgement that a lot of expertise exists within our state. We didn't have to go outside for everything, or some of the people in our state had already gone outside and gotten the training, so let's draw on that and use that. But it really highlighted the need for the association, our association, the PIHPs as the primary funding vehicle, and the CMH as the primary service providers to take the lead in this whole effort. So they had to select some evidence-based practices. Well, how are you going to do that? There was extensive discussion about levels of evidence-based practice, and what's that really mean? Well, as you talk about fidelity, as you talk about implementation, as you talk about scope of implementation, there's a lot of different things to consider. We'll talk more about this, but is fidelity the the price of admission and the ticket to play? In other words, you don't get to do it unless you're full fidelity. Or is fidelity a quality improvement process where you continually work for greater fidelity? At what level do we implement this? Is it at the whole state, all across the state? Is it in urban areas? Is it specific pilots? Is it through the PIHP, CMHP? There's a lot of discussion of levels of evidence-based practices. And they had a number of presentations of unique evidence-based practices. And there was also extensive discussion on thwarting innovation. Innovation and local adaptation is possible with expert consensus. And this goes back to the differences across our system. We are a public mental health system that has its roots in a county-based system. Now, many boards are multi-county, but if you look at the mental health code, if you go back to our state constitution, this is a county-based system that was built to meet the unique needs in each county. Now, as we've sold our soul to Medicaid, which was a very good thing to do because we need the money, it's funded our system, we are now a county-based system subject to federal regulations in a state-run operation, but we can't lose that county level, that local uniqueness that makes us who we are. So that was the how of the selection of evidence-based practices, but why did they start where they did? Because they settled on nationally accepted evidence-based practices that met that earlier definition as a starting point. They also decided that they needed to use linkages within the state with existing national experts and linkages to the SAMHSA toolkits, and we'll talk more about that, and also the Parent Management Training Oregon model, or PMTO, which is not an evidence-based practice on the SAMHSA site, but it was a practice they wanted to bring in. They also wanted to encourage innovation and development of other evidence-based practices. So the choices that they made were to accomplish this, to have that starting point, to tie to existing expertise and the SAMHSA toolkits, and to encourage further innovation and development. So the SAMHSA toolkits, what's this? Evidence-based practice toolkits for adults with serious mental illness on the SAMHSA website. SAMHSA, of course, being the Substance Abuse Mental Health Services Administration in the federal government. When I started doing this presentation in about 2011, 2010, these are the toolkits that were there. Assertive community treatment, you should all know what that is. We've been doing it in Michigan for many, many, many years. Integrated dual disorder treatment, that's IDDT. COD is often added to that, co-occurring disorders. That's been implemented. Illness management and recovery, supported employment for persons with mental illness, family psychoeducation, and then a kind of a collection of medication management approaches. That's what was on the toolkit, on the website 5-6 years ago. Now there are all those and more. There's supported education evidence-based practices. There's treatment of depression in older adults. There's interventions for disruptive behavior disorders. There's consumer-operated services. There's something now called MedTeam, medication treatment, evaluation, and management. There's a practice for permanent supportive housing. So as you can see, this has grown and expanded. Well, what about people with intellectual and developmental disabilities? There were some promising practices, such as self-determination, but not a real source of evidence-based practices. So in the state, we created the Developmental Disabilities Practice Improvement Team, or commonly called the DD-PIT. Now it would be called the IDD-PIT. And their role was to evaluate various practices, seek improvements. This was the group addressing services to persons with dual diagnosis of an IDD and a mental illness, and that group has made a number of recommendations. There's also been a group that's helped review a lot of the autism benefit, or the applied behavioral analysis that we've been implementing over the last couple of years. The DD-PIT is still active, I will say, and working now a lot with the core indicator measures, and you've probably heard something about that. That's a national measure of some quality of life factors. What about evidence-based practices for kids? Initially, we talked about trauma-focused cognitive behavioral therapy. We talked about parent management training Oregon model. And there were some promising practices such as multi-family groups for prevention of schizophrenia. This has grown. There are more in place now. This has not been addressed systemically by the state. Various CMHs have done it. You may have some within your own CMH that I'm not listing here. There are a number of them, but they haven't been pushed as much by the state. Now, what about substance abuse treatment? We are now integrated substance use disorder and mental health services. So there is the Institute for Research, Education, and Training in Addictions, IRETA, recovery model. There's stages of change, and there's motivational interviewing. These aren't technically evidence-based practices, but they are best and promising practices, and they are in place. I want to refer you to a website that DCH did create. It's called improvingmypractices.org. And this was set up, and it currently lists a whole lot of practices that are in use here in the state, and then each of these has the information on the website about it. So what are there? Assertive community treatment, case management, not truly an evidence-based practice, but we have, as a system, developed some core competencies for that. Clubhouse, or psychosocial rehabilitation. Co-occurring disorder treatment, integrated dual disorders, that we already talked about. Cognitive behavioral therapy, dialectic behavioral therapy, family psychoeducation, independent placement and support, motivational enhancement, motivational interviewing, supports coordination, like case management, again, there are core competencies, supported housing, trauma-informed services, trauma-specific treatment, such as trauma recovery and empowerment model, TREM or MTREM, and seeking safety. These are all out there on that website. And I encourage you to go look at it sometime. Without a login, you can only get so far, but there's good information there. And that will help you understand some of where this has come over the years. So, where exactly is here? What did we do and what are we doing? I've talked a lot about what evidence-based practices are. I've talked about where you can find some more information. But what have we done? Where are we? The statewide implementation team had certain leadership roles. MDCH provided the vision and leadership and the resource development and support. Universities in Michigan provided evaluation and fidelity monitoring and fidelity leadership. Maybe it was Mary Ruffalo from the University of Michigan School of Social Work. I know that Wayne State has done a lot of work. Wayne State's doing some work now on the transition surveys for home and community-based service rules. So the universities have been a big part of our system in helping us move things forward. PIHPs and CMHSPs, we had to identify internal systems champions or change agents. That is so important because if you want to affect change, again, change is good, you go first. Well, if you really want to affect change, you've got to have people internal to your organization who lead it. Because as a social worker, as a staff in an organization, I'm going to buy into something more when my coworker over here at the desk next to me is enthusiastic about it. So you've got to identify those. And for board members, that's an important thing to understand because perhaps it's some extra training, perhaps it's impacted by turnover, but you need to understand the importance of those internal systems change champions. Supervision and consultation to the local level. That's real important. Supervision of evidence-based practices is not just typical supervision. It has to come with that expertise. Now, if you've got a staff member who's being trained in PMTO and their supervisor is not trained in PMTO, who's going to give them that supervision? So we've shared resources on that. The association, they've provided ongoing training and support for all of this. And in fact, I'll mention a little bit later, some of this, there's now a integrated healthcare learning collaborative or community that our association is very important in supporting. And national experts, we brought them into the state, in-state consultation and training. They have assisted with various local modifications. PMTO, the Parent Management Training, Oregon model. We've done modifications to that. We've applied it to some group activities. We did that with the assistance of the experts. And as we've moved forward, and as we continue to move forward, I just mentioned the Integrated Healthcare Learning Collaborative. DCH provided the funding and the leadership for this. Universities provided evaluation. The PIHPs and the CMHSPs commit staff time to learning and to the process of this. And our association manages the collaborative activities. This has been a really good model. It brings people together. It's still active today. It grew out of some trainings that we initiated in the state for integrated care, 3 leadership level trainings in 2012, that then led to the development, and the state agreed to fund this Learning Collaborative. And it's been a really effective tool that brings people together on a regular basis with some expert training, but then also sharing. And the various CMHs come in and the teams share with each other what they're doing, and it really helps. This has tremendous potential, excellent learning opportunity for staff throughout the system. I'm really pleased that this got going, and I hope people continue to take full advantage of it. Integrated care, physical health and behavioral health, the Learning Collaborative is ongoing, but what else do we have? These are some new tools for us. Data analytics. Data analytics you've probably heard about it by now. As board members, you've probably been asked to help fund it. If not, at the PIHP level, they certainly have. What is it? It's taking the data available, typically claims data, but you can also add more to it. And it gives you the tool to do individual care management, to do population level analysis, and to identify health disparities. So what's that mean? Individual care management. Knowing we only see a certain part of what goes on with the people we serve. For the population with intellectual developmental disabilities, we typically are much more involved in their life. We know if they get health care. But a lot of the people with mental illness that we are treating and working with, we may not know if they get to the ER for something other than a mental health issue. We may not know how involved they are in certain areas. Through data analytics, we now can know that. So we can know if someone's taking care of their diabetes. We can know if someone's been in the ER 5 times recently because of their asthma. We can identify this stuff and help manage their care. We can work with their other providers and coordinate things. And there are just so many studies out there now that show the benefits of that in terms of quality of life and health. Population level analysis. We need to be able to identify across our population what are the major health trends, behavioral health and physical health. How prevalent is obesity? How prevalent is diabetes? Any of these, congestive heart failure, you name it. Understanding where that is in our population and what the highest risks are is important, because we are becoming increasingly accountable for population health outcomes. And then identification of health disparities. Why is it? And maybe there isn't an answer, but why is it that one part of your region perhaps has a very different set of health concerns than another part of your region? This becomes more important at a regional level and a health plan level, but it's also critical at a CMH level, especially for multi-county CMHs. So as a board member, if you haven't already heard about data analytics, you will be, and you should be asking about these things, about how you're doing care management, about what kind of population level analysis is going on in population health outcomes. Then the health home pilot. Some of you may be aware that the Affordable Care Act, Section 2703, allows funding for behavioral health homes. Well, what's a health home? Let me be clear, it's not a house. It's not where someone goes and lives. A health home is your central location for your care management. Many of you, if you've got a primary care doc, they may now be, many primary care offices are now patient-centered medical homes. Well, in behavioral health, we're calling them health homes. But that's where your care coordination happens. We know through anecdotal evidence, through research evidence, that people with serious mental illness, people we serve, do better when their care is managed by our system than when it's managed by the primary care. Why? We're set up for it. I'm not slamming primary care in any way, shape, or form. They're critical to health care. But a primary care doc is seeing 30 or more people a day. That doesn't allow the time that it takes for many of the people we serve. They are more comfortable with us. So, Section 2703 allows for the establishment of these health homes. There are three piloted in Michigan right now, 2 funded by the state, one in Grand Traverse County, one in Manistee County, and another being done in Washtenaw County, where they came up with their own local dollars for it. There was a state plan amendment for it. It is a pilot to move toward this. Enrollment's been slower than we thought, but it's coming along and it's very promising. There are various integration projects statewide running the whole gamut from referral arrangements to some co-location to complete integration. There is a whole continuum of integrated care, and it can really be described along this kind of a trail. Universal screening, screening for other conditions, the pH9, taking weight and blood pressure and BMI. Most CMHs are starting to do this now, the weight and blood pressure and the BMI, but for a long time we didn't. Now that's just the initial step where you start to screen for some of these conditions. We've had for some time in our demographics a set of health measures we have to complete. Hopefully those can go away as we have more of the data analytics because we'll have more reliable information on people's health conditions. Then navigators. This goes beyond referral. It assists in accessing and moving through the healthcare system. And if you think about that, that's really important. I told you the cancer story earlier. I can tell you the doctor called with the diagnosis the day before the visit. And so the next day at the visit, we were like, well, why did you call us with this when we were seeing you today? He says, well, you know, I've found that as soon as I tell someone that they have cancer, they don't hear anything else I say for that entire visit. And he's right. And what that did was it gave us time to do some research. Well, think about not just cancer, think about any healthcare condition. Think about your own ability to navigate our healthcare system. It's complicated. Now, add to that schizophrenia, maybe some paranoia, maybe some delusional thinking or some psychosis. Wouldn't a navigator helping you navigate through that be really beneficial? Of course it is. The next step, co-location. You capture both in one location. And this can be either placing some primary care, a physician or a nurse practitioner in a behavioral health clinic, or placing a behavioral health person in a primary care clinic. And we're seeing that. There's examples of therapists being located in FQHCs, the federally qualified health centers. There's examples of bringing docs into the CMH centers. And then full co-location is putting it all together. And we have some. You might have heard of the Cherry Street Clinic in Grand Rapids, Manistee, Central Wellness Network, Manistee-Benzie. Their entire Manistee County clinical operation is co-located with a primary care clinic. It's really cool. That's full co-location. And then I mentioned the Health Home Pilots. The Affordable Care Act offers 90% federal match for 8 quarters. After that, it goes to the normal match, but by that point, you should be able to demonstrate enough savings from this that you can afford to maintain it. System level integration of care. This goes even beyond the delivery level. That's purchaser, plan, provider type integration. That's where we're headed. That's not where we are. But still, local is what matters. So local implementation team process. How do you do this? As board members, you need to understand how some of this works. You need a charge. You need a work plan, a diagram. Any group that is supposed to do something needs to know what it is they're supposed to do. You need follow-up training and support. That's things like these ongoing learning collaboratives. Because what you find is you can train people, but once they start to apply it, they identify what didn't get covered. This was real clear in Missouri. Missouri was the first state to get a health home state plan amendment. And when we visited with people in Missouri about this, what they learned as they implemented it was, in spite of all the training they did in advance, as their health coaches started working with people, they encountered things they never anticipated. So having an ongoing learning collaborative or learning community with monthly phone calls gave them the opportunity to bring this up to experts and to each other and to identify the answers. So follow-up training, it's not one and done. Training has to be ongoing. Board support, that is critical, and that's where you come into this. You have to support this, you have to understand what it means. And you can't support something unless you know something about it. So it's really critical that you understand integration of care, that you understand evidence-based practices so that you support that being done. And of course, executive director support. What happens in a CMH depends on what the executive director supports and wants to have happen. So the executive director has to support these changes. And then local champions, these change agents within your system. That has to happen in order for change to take roots and to hold. This isn't new. This is quality improvement. This is standard change management, but we're just applying it to some new challenges. And of course, you need these new tools. Data analytics, which I talked about. Care management. Don't confuse that with case management. Case management is coordinating, linking, assessing. and it's a specific service. Care management is bringing together and identifying and planning all the care. HIE, Health Information Exchange, electronic health information exchange. Many CMHs are moving forward into this right now. I know the CMHs in my region are very close to signing on with a qualified organization to do health information exchange. To do it, you have to have an electronic record. You can't exchange things electronically unless it is electronic. It's very critical to staying abreast of things. One of the things that's gotten incentivized by Blue Cross Blue Shield, largest payer in the state, is the exchange of what's called ADTs, admission, discharge, and transfers. Something about 95% of the hospitals in the state of Michigan are now doing that electronically. Well, what's that mean? That means if you are part of this HIE, Health Information Exchange, anytime someone on your active care registry, those people that you are actively serving, anytime one of them is admitted, discharged, or transferred from an emergency room or a hospital, you would get a notice for that if they've consented to this communication. Think about how valuable that'd be. They might be out of your area. It might be something you don't get called on because it's diabetes, asthma, whatever. Now you'll get notified of it. That's critical to care management and effective care for people. So these are new tools. So as board members, you're going to be asked to fund this stuff. You're going to have to understand it. And so this is the process, and this is what we're still working through. Financing evidence-based practices. This was not an unfunded mandate. I don't think. Let's talk about that. The promise of evidence-based practices is that they pay for themselves via consumer improvement and reduced costs elsewhere. Okay, that's logical. That makes sense. I have not seen any solid report of that. I've just got to be honest. Intuitively, it makes sense. Evidence-based practices get you better results. They can shorten treatment. They can reduce the cost. But I haven't seen solid evidence of that in Michigan's CMH system. I'm not saying it's not happening. I'm just telling you, if you asked me to prove it, I could not. Current funds and staffing are shifted. This is critical. To do this, you've got to replace something. It can't be a constant add-on. Okay, now we're going to do this evidence-based practice. Now we're going to do this evidence-based practice. Now we're going to do that evidence-based practice. And meanwhile, they're still doing everything they always did before. It has to replace some things. And it should, because it should replace antiquated practices that aren't evidence-based. So things get shifted. External supports are included. This draws on other circle of support, if you will. NAMI, family members, etc. The family psychoeducation program is a problem-solving process teaching the people we serve and their family support system, whether it's actual blood family or their support system, how to problem solve better, which helps them maintain their recovery. Staff retention is higher. Think back to what I said about better outcomes, less stress, better job satisfaction for your staff. Well, staff retention is higher. Now, there's a downside to that. What also happens is as we've trained staff in evidence-based practices, too many times we've seen other organizations snap them up because they're now worth more. So that's a balancing act. Long term, as all staff know this stuff, as it becomes fully integrated into our practice, it will increase staff retention because it will make the job more rewarding. Positive consumer outcomes are nearly guaranteed if practice guidelines are followed. This is true. Now, not 100% guaranteed, but the evidence shows that in X percent, you get better outcomes. So that makes sense that if you use these, you're going to see improved consumer outcomes. Is this what we're seeing? Well, let's go back to that comment I made earlier about having standardized measures and outcomes. We don't have that across the state, so it's hard to say. We can't prove it. Evidence-based practice implementations, ACT. We've been doing this for years in Michigan. We did this before we really got on the evidence-based practice kick. FPE, multifamily psychoeducation, integrated dual disorders treatment for co-occurring disorders. Those were the first two that were funded. FPE and IDDT were the first two funded through block grants, and we had the choice of one or the other. Well, then the next round of block grants, we had to do the one we hadn't done. Parent management training, Oregon model, that was never required. It was a competitive grant process, very expensive training process, but a number of places have done it. Not all CMHs have, some have. Supported employment for adults with serious mental illness, that became funded through block grants. Illness management and recovery, a number of CMHs have done this through their PIHPs or individually. That was never mandated by the state. Autism benefit or the applied behavioral analysis, that's an evidence-based practice that we're all implementing now. The health home pilot sites are learning about various evidence-based and promising practices for integrated care. And as I said, across the state, there are various others being implemented. You're seeing a lot of DBT, dialectic behavioral treatment. That's a very intensive program to do to full model fidelity. It requires 24-hour on call, it requires a team approach. You are seeing it in places, not everywhere. CBT, cognitive behavioral therapy. So there's a number of other evidence-based practices you see around the state, a lot of kids practices, but they haven't been systemically done throughout the state. Good evidence-based practices require fidelity measurement. If you're going to do it and do it well, you have to measure that you're doing it to the model. And fidelity measurement is the extent to which a particular treatment or program is consistent with that model. It can be assessed in a variety of ways. Carefully developed scales are used and expert consensus. Effectiveness and fidelity are directly related. You're not going to have as much success in getting the intended outcomes if you don't have high fidelity. And it ensures that whatever is being measured is related to the evidence-based practice rather than to billing or productivity. It's not about how many widgets did you produce or how many hours of this did you do. It's about, did you do this the way it was supposed to be done, and then what are the outcomes? Good evidence-based practice also requires outcome measurement. Again, I'm going to go back to this because you're going to hear about it in the next year or so. Outcome measurement requires some sort of a consistent tool. That allows for a determination of effectiveness, and it's important to know whether a treatment is working or not. So how do we know that other than anecdotally? Now, this is not without challenges, though. Even aside from the challenge of getting a common tool, there are other challenges. Better outcomes than what? Generally, these services are not delivered in isolation. So is this outcome because of the family psychoeducation that they're getting, or is this outcome because the psychiatrist just changed their meds and they're on a better medication than they were before? So how do you measure this? When you talk about it, there are so many variables that could be impacting it. So there's those issues. Better than what? It's not done in isolation, and we don't have a common measure across the state. I keep going back to that because that's coming. It will come, you'll hear about it, and just understand there's a wide variety of opinions about it. It's necessary in the environment we're in. So what are some important board member takeaways from this? And I'm not done yet, but what are some important takeaways for you? Review your existing programs for evidence-based practice. Is your organization using evidence-based practices, and how many? And what are the outcomes for consumers in your area? How and when do you as a board review any of this? Do you get regular reports of outcomes? Now, I don't want a bunch of directors calling me all angry. What did Schneider tell them to do? But as a board member, you should be thinking that. And what are the timeframes that these outcomes are achieved? And how broad is it? Oh yeah, we're doing this evidence-based practice. We got 5 of them. Yeah, it's touching about 2% of our client base. So there's a lot of things that you should be asking if you're not getting these reports. Hopefully you are. But if you're not, ask the question. Anytime a new program is suggested, maybe you have a program committee at your board, several do, and any new program gets reviewed somehow by a board. Is it evidence-based? If not, why not? I'm not saying you can't implement anything that's not, but you should ask that question. If it's not, is there an evidence-based practice that could do what we're trying to do? Review all new programs or suggested programs for a relationship to evidence-based practices. Create your own data to generate a new one. If there isn't one out there for something, a need you've identified, could you perhaps start collecting the data and create a new evidence-based practice? It's worth an ask. Maybe your board isn't going to do that, but it's worth asking the question. So those are some takeaways. Now let's talk about a couple more things. Evidence-based practice or practice-based evidence? What matters more? Process fidelity or service outcomes? Let's dig into this a little bit. Michigan's mental health services. In 2006, NAMI gave the state of Michigan a grade of C for our overall health services. In 2009, a few years after striving to implement multiple evidence-based practices, the state of Michigan received a D. What's wrong with this picture? Well, perhaps a lot of things, but let's dig into it a little bit. There is a high cost for high-fidelity evidence-based practices. Now, this is just a chart that's intended to help you understand some of this. And it lists various practices down the side here. But then, what are the issues here? Staffing level. ACT has a certain staffing ratio, 10 to 1. 10 consumers to a team per each staff, and certain requirements. Family Psycho-Ed requires 2 people to run a group. IDDT COD should be done in a team setting, so it tends to get stuck with ACT in many cases. Initial training. What's the cost of training for all of this? People have to get trained, and then ongoing training. Well, training has a lot of cost to it. We all know that. Training too often is the thing that gets shorted because budgets are tight. I'm not telling you anything you don't already know. So how much money can you put into initial training for new things? And then you have to have ongoing training. Fidelity reviews. How do you do this? Well, again, that's taking time away from services because people have to answer questions. Someone's got to come do it. There's a cost to that. Same thing back on the training costs. It's not only a cost to pay for the training, it's time away from services. And then opportunity costs. What else could you have done with that money you spent on training and on fidelity reviews and on increased staffing levels? So all of this has to be considered, and I'm not telling you what the answer is. I'm telling you as board members some of the things to be considered. High cost, there's a high cost to high fidelity evidence-based practices. So the elephant in the room, is there an elephant in the room? As additional evidence-based practices become strongly recommended or mandated, but don't come along with any additional resources for sustainability, at what point does a limited resource public sector provider reach its limit to implement and sustain multiple evidence-based practices at a high level of model fidelity? In other words, when does the good become the enemy of the better? So what I'm saying here is not that people don't deserve evidence-based practices, not that we don't need to be moving that direction, but we have to keep in mind that we have limited resources and we have to evaluate how we do this. And we need to start proving that evidence-based practices get us quicker results or better results at less cost to support this continued movement. There's an inherent belief by many that they do. We haven't proved it, and we need to. And that's going to help you as board members understand as you make these tough decisions why you will make the decision and what decision to make. It goes back to that whole thing of outcome measures and being able to support what we want to do. So now let's talk about how do people change and why do they change. That's what recovery is. It's people making some changes. 50 years of research has shown that there are 4 key factors. First, relationship with an agent of change. The therapist, the doctor, the case manager, a sponsor for AA and 12-step meetings, the pastor, a friend, a family member, etc. The relationship with that person plays 30%, a factor of 30% in how much people change. That's significant. The treatment modality is very important. What technique, what method, what model of change is used, what procedure. But that's 15%. Individual change factors, including a willingness and a readiness for change, is 40%. This is really true in many cases of what we're dealing with. You know, you treat diabetes, there's medications and processes you go through, but we're talking, and with chronic conditions, we're talking also changes in behavior. The diabetic has to change his diet. Well, their willingness to change is a big factor on this. The common cold, you take medicine, it gets better. It doesn't really matter what your attitude is. But these things it does. Substance use disorders, readiness and willingness to change is huge. Recovery from a mental illness, readiness and willingness to change is huge. That's 40%. And then finally, the individual's belief that change is possible, their hope, their confidence that this can go somewhere is another 15%. So let's look at this for a minute. What's this saying? 70% of change is related to the relationship with the agent or agent of change, the therapist or case manager, or to that individual's willingness and readiness to change. 70%. So what particular treatment is used is only 15%. So what's the difference? Well, it still matters because that 15% is critical. So you've got to put this in perspective. This could get thrown at you as a reason it's not important. What it really says is it is important, and you have to convince the person that this is what they want. Your therapist, your case managers have to believe in evidence-based practices because it's their relationship with the person that's critical. The individual being served has to be ready to change, and they have to believe that this particular program, this evidence-based practice, will help them get there. So it does all tie together. So some perspectives on this. It is a theoretical hypothesis that implementing an evidence-based practice will automatically lead to improved outcomes. There is overwhelming evidence that points to the quality of the treatment relationship being the most significant indicator of beneficial outcomes, twice as significant as the treatment modality being used. Yes, so use that. That goes back to the individual providing the service has to believe in this and still has to be able to engage their consumer. And even if evidence-based practices do result in better outcomes, are the outcome gains worth the involved costs as contrasted with other approaches that could be equally or even more efficacious? So again, we talked about the high cost. We need the measures to show that the outcomes are that much better too. Again, I'm sounding like a broken record, but some consistent measures across the state. Another perspective, the reality is that a number of evidence-based practice models were researched and normed on client populations that are not the same as the seriously mentally ill consumers that we serve. So high-fidelity implementation may not actually be indicated. Goodness of fit matters, yet local adjustments to evidence-based practices may violate model fidelity and disqualify providers from being considered excellent or effective practitioners. So again, remember what I said earlier about we are local, every community is different, we need to fit this. So fidelity, in my mind, I'm going to tell you fidelity is a quality improvement thing, not a price of admission. Additionally, the evidence-based practice label is gained by demonstrating through duplicated research that the model in question is better than a placebo or treatment as usual, not that it is better than alternative models of treatment. So is it really surprising that ACT or IDDT shows better results in lower resourced treatment as usual or no treatment whatsoever? No, of course it's not surprising. So we've got to keep this perspective. Evidence-based practices are good, they're valuable, but let's understand this. The tests compare them to a placebo. We're not doing placebos. There is ongoing interest in the issue of high fidelity implementation and the outcomes achieved. But who's interested in this? Well, researchers are interested in it. Are your consumers? No. They're interested in improvement. So fidelity has to be there enough to get the results. We just have to keep it in perspective. This requires the identification of common outcome measures so that changes in fidelity can be evaluated in terms of impact on outcome. Again, I'm back to those common measures. If CMHA has high fidelity and gets outcomes at, pick a number, 75%, and CMHD has less fidelity, but fair, and gets outcomes at 75%, and CMHH has horrible fidelity and gets outcomes at 50%, then we know that fidelity is important, but perhaps maybe not that last 20%. Remember the 80-20 rule. Maybe the gain is in the 80%. This effort has been a challenge, but is central to the next emerging issue, and that's sustainability. As noted before, DCH provided grant funding for implementation, but maintaining fidelity is challenging. Staff do turn over. How do you train new staff? How do you keep them with the ongoing training? How do you keep consumers interested in it? How do we ensure sustainability of the evidence-based practices that we've implemented? When I look at the data, it's one of my goals from my board to implement evidence-based practices across the region. But at the same time, we've got some CMHs looking at working with the state about getting out of some evidence-based practices because perhaps there's newer models, or perhaps because of the cost in the rural area, there are more effective, less costly options. How do we assure this? We have to have the measures in place. How do we make an additional practice implementation reasonable? The other problem we have is we keep implementing this with the same staff. If you've got a multi-county CMH, you might have a limited number of staff in a county. And if you want to put 3 different evidence-based practices in there, are you putting it all on the same staff every time? You've got to consider that, and how many more of them can you do, and how many can you do reasonably? This whole thing of sustainability was the focus of considerable attention from the Practice Improvement Steering Committee, the statewide committee that oversees all this. And they had help from Mary Ruffalo, PhD, from the University of Michigan. And these are some themes that emerged from Dr. Ruffalo's study. Organizational factors, for example, turnover, cost, and communication are key to sustainability. Training, again, this takes staff away from regular work, so that's key to sustainability. Staff involvement in multiple evidence-based practices is a key theme and issue to be addressed. Consumer knowledge and interest. How are we educating consumers about this? If you think about it, someone starts to explain something new to you, or you could have what you've always known. Many people's initial response is, no, that's okay, I'm good with this. So how are we going to educate people and continue to do that to maintain some interest? Environmental issues such as urban and rural differences significantly impact sustainability. Fidelity, difficult to monitor. What is the standard? And again, is this a QI thing or is this the price to play? Technology, both in terms of electronic medical records, but also in terms of technology for training, is a key issue in sustainability. And billing. When can we report the codes for evidence-based practice, and who makes that decision? That's important. Some organizational guidelines for sustainability that Dr. Ruffalo started to identify: initial and permanent funding. It has to be ongoing. Dedicated champions. I've talked about change agents. Training and technology-enhanced training. Are we doing enough with distance learning? Are we doing enough with video conferencing? Are we doing enough with webinars? Now, this was a couple years ago that she did this, and it has grown tremendously, but it's a key consideration. Continuous internal fidelity monitoring. This reminds me of back when I was responsible for accreditation at a CMH. And same thing with DCH site reviews. You've got organizations where the day before a review, everyone's all crazy and going nuts the 2 weeks before. If you've been doing this right, the review's just another day because you've been reviewing it ongoing. And that's the way this needs to be. Internal fidelity monitoring should be continuous. Ongoing evidence-based practice supervision. Again, remember I talked about if the clinical supervisor has not been trained in that, where does the clinician doing the evidence-based practice get ongoing supervision about the evidence-based practice? Leadership support. Do your clinical leaders, do your CEOs support this? It's critical. Low staff turnover is important to sustaining this. If you've got staff turning over all the time, that just greatly exacerbates the cost of training. And universities have to begin to incorporate this into their curriculums, at least the common core competencies of evidence-based practices. Evidence-based practices must be matched to consumers' needs and desires, and we must demonstrate positive recovery outcomes. When all that gets addressed, sustainability becomes a piece of cake. Dr. Ruffalo addressed training and common elements of evidence-based practices with the potential for certain training modules that bring together the common elements. And what are they? Relationship building and stages of change. You find those in almost any evidence-based practice. Cognitive behavioral essentials, behavioral methods, acceptance-based strategies, motivational enhancement strategies, problem solving, social skill and support building. These are core pieces of most evidence-based practices. So perhaps, rather than doing specific trainings for each evidence-based practice, we need curriculums and training modules on these topics that then become applicable to any of them. I can't tell you the current status of these. Dr. Ruffalo was working on them, and I don't know what she's done since then. The new issue, broader use and sustainability. As noted previously, DCH created the website, improvingmypractices.org. As healthcare system moves to greater integration of primary and behavioral healthcare, the public mental health system will need awareness and understanding of a whole new array of evidence-based practices. Applying experience gained through implementing evidence-based practices to preparing for integrated care will save us a lot of time, it will benefit us, and we will learn. So again, it's like everything old is new again. We've got to learn from what we've learned. We have to apply this as we keep learning new things. There's no end to it. It doesn't, someone asked me, when's all this change going to stop, David? And I said, it's not. Someone asked me once, when are you going to stop having to buy more computers all the time? I said, I'm not. This is the reality of the world we're in. But let's learn from what we've done so that as we go forward, we can do better. That's best practices. I hope it's been helpful. If you do have questions, you can contact the association, and I'm sure they can help you get the answers. Thank you.